Um, these, they may have difficult with transitions. I have some children that have difficulty from a sensory perspective transitioning from the waiting room into my office. I have children who don't like to get dirty on their hands. They may have difficulty filtering out environmental sounds. And, you know, practicing in this city, when I think of environmental sounds, we have fire engines. 5 times a day, the fire trucks are going by, police cars. But there are also other environmental noises, such as a vacuum or a hair dryer. They can't filter out those sounds. Some children pigeonhole themselves into eating just one texture. It could just be purees. It could just be pasta, a soft texture. So they may eat purees, they may eat some pasta. These are also the children who don't like to have their teeth brushed. I also have a lot of children that parents will say to me, oh gosh, as an infant, they eat everything, but yet when we had to transition them to solid food, it was really difficult. And they started to refuse. And not only could it be sensory, it could be also a little behaviorally, because now think about the sensory system again. They've gone into that fright, fight, flight mode. They're afraid. So their experience was limited. And when I say experience, the sensory experience was limited. And that they didn't have the opportunity to develop the sensory skills and the motor skills to handle a wide variety of foods. So your parents will also often ask me, well, gosh, you know, they're just still on pureed food. I'm like, well, then the tongue never has the opportunity to develop. Again, go back to the muscles we use in feeding are the muscles we use in speech production. So what happens? A child comes to me and I develop what we call a pre-feeding program. And it's designed to support motor skills that support safe, effective, and nutritive feeding. I also work to decrease oral sensitivity, but I also work on tactile sensitivity. I sometimes have to work on increasing oral sensory awareness and also increase motor function. I want to go back to the tactile. You know, we are tactile beings. I'm going to talk to the ladies for a moment. Sorry, Sheldon. You know, when I go to the clothes store and I look for a new blouse or a new sweater, the first thing I do, I touch it. It sends a signal to my brain like, oh, I like the way that feels. I'm going to like the way it is on my body. Now, and we've all had this experience. I may see the most beautiful blouse or the most beautiful sweater. Again, I go to touch it and my hand does this. I don't like the way that feels. And I quickly move on. Think about food. If you're touching something, if you're touching a piece of food and you don't like the way it feels, are you going to put it in your mouth? Probably not. Now, we all have normal sensory levels. So I give the example to my parents of, what if I gave you a little pebble and I told you to eat it? Right away, you're gonna be like, I can't eat this. I don't like the way it feels. If you don't like the way it feels on your hands, you're certainly not going to like how it feels in your mouth. So the goal of my program is to develop a set of exercises that can promote safe feeding and promote strong oral motor skills. So now let's talk a little bit about motor development. I'd like you to understand the feeding skills that we need for motor function for both feeding and speech. So let's go all the way back to the beginning. You have a baby, and for the first 0 to 3 months, the baby is suckling, getting a lot of tongue protrusion, getting a little retraction. If I were to give them a bottle with the nipple, the lips are sealing onto the nipple, but the tongue, we call it cupping and grooving. So it looks like this. And what happens, that nipple goes right in, and then the palate and the nipple kind of form a seal, and they start that nutritive sucking. But also this muscle right here, this is the buccinator muscle, and it's a long sling muscle. So when we suck, it looks like this. And you can see that function. So the cheeks, also those fatty sucking pads, aid in bringing the liquids in. Think about speech for a moment. From 0 to 3 months, nothing much is happening except, oh, ooh, look at my lips round. Ooh, because they're getting that muscle, that little muscle workout from drinking. Now, from 4 to 6 months, I look at 4 to 6 months as probably the most important part of feeding and motor development. The jaw, if you think about 4 to 6 months, we're starting to introduce some purees. So now, sensory. We're getting some sensory information to the mouth. Now the tongue has to do something. So the tongue will move it to the side just a little bit, because now the gag reflex is going further back, but also the jaw is starting to work in what we call a munch chew pattern, because it's getting sensory information. The tongue is now, instead of going so far out the mouth, it's becoming more retracted, because now you have that puree that you have to move little side to side, and then you have to swallow. Let's think about speech. So if we're starting to spoon feed and the lips are starting to get more information, look at how those lips are working. They're starting to come together. What typically happens during 4 to 6 months? We may get some mama, mama, mum, ba, 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 because now the sensory function has innervated the motor function, and it sends a signal to your brain, and we're born with millions of neurons and neuron synapse. That's right. My lips come together to go ma or ba or pa. 7 to 9 months, we're getting more movement of the tongue at this point. Think about what happens at 7 to 9 months. The purees are thicker. We're starting to give babies meltaways, or very easily dissolvable food. We may be giving them some toast. We may be giving them anything that I refer to as semi-solid, something you can crush with your finger very easily. So the tongue is moving more, the lips are moving more, we're getting more side to side, active side to side movement, and we're starting to see the development of the jaw muscle. If you bite down on your back molar, that's your jaw muscle. That's the masseter muscle. It's the strongest muscle that we have in our face, and it's getting input. And remember that, because when I talk about teeth grinding later, we're going to go back to that muscle. What's happening with speech? Sensory. Sensory innervating the motor function. And as parents, we're like, oh yeah, that's so cute. Look at you. Ba, 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 da, 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 da. And they may start doing some imitation skills. So now we're now up to 10 to 12 months. The lips are now tensing, getting tighter and working more. We're having a more active swallow. The upper lip is folding under, the lower lip is retracting. Tongue movements, when we swallow, we're getting more tongue retraction and more tongue tensing. Now think about, we've gone from birth all the way to 12 months because now food is, we've gone from that semi-solid to more of that solid food. What's happening at 12 months? The first word typically emerges, mama. Oh, think about, it's taken 12 months to get to that point. Go back to feeding. What did feeding do for those 12 months? It worked on the motor function for chewing and for speech. So I want to take a moment to give you a diagram. So when I look at a child, I look at, oh, I'm sorry, I just want to change that color. Okay. I look at 3 muscle groups. And I'm going to just draw these circles. I'm going to change that back to red. I look at, whoops, the jaw, the lips, and the tongue. Okay, so now envision 6 of the strongest men in the world come together. Now the 3 who are the strongest, they need to get on the bottom. They need to create stability. They need to create stability for the guys up here. Now, think about the jaw. If we have stability, we have what we call mobility. Sarah taught me that very early on. So if those jaw muscles are strong enough, the lips and the tongue can function independently. But if for some reason we lost stability, we've lost mobility. And my pyramid, these top guys, remember, go back to the strongest men. These are the weaker guys are on the bottom now. These guys are a little stronger. They're going to fall off. The bottom guys now do not have the stability to support the guys on the top. So how does this all pertain to speech? So children that I often treat who have sensory and motor feeding issues often have speech or speech clarity issues. They don't have the oral placement skills to support sound production. So what is oral placement skills? Think of the sound. Let's go back to our ba. Everybody can just make that sound out loud. Ba. What did your lips do? If your lips were retracted and I asked you to make that ba sound, it's going to be pretty hard to do that. Go back to my pyramid. The jaw is not strong enough. The lips can't do their work. If my mouth is in an open position, maybe I could do it, but that's not really effective oral placement. Oral placement therapy, or OPT, adds the tactile component for awareness, placement, and more importantly, muscle memory. I want to speak about muscle memory for a moment, go back to all those neurons floating around. And when a motor function is made, the neurons synapse, and we create a lifelong motor function. So I always ask parents one or two questions. When was the last time you went ice skating? Or when was the last time you rode a bike? For me, it's been a while since I did both. But if I had an ice rink right outside, or I had a bicycle, I would know what to do. Why? Because long time ago, those neurons created the motor function because I have muscle memory. Speech is the same. You need to have muscle memory for the motor function. So I want to show you some videos now. We'll take a little break from the lecture. So I am fortunate enough to work with Bina's daughter, Karina, and I've been working with her for several years. And I want to show you a couple of the techniques that I've done with Karina, some for the benefit of the lecture today. Some of the other videos you'll see of her are still exercises that are in our repertoire. So the first one I'm going to show you is just some facial massage. When a child comes into me with sensory issues, I always start on their body. I'm for the most part a stranger to them, but I always start on their body, and then I get to their face. It's kind of like going to the dentist. Would you just want somebody to come right up to you and just start going into your mouth to facilitate motor function? Probably not. So I always just start gently on the body and go right to the face. So the first video you'll see is just a video of me doing just some facial massage with Karina. And you can see how I go along. I stretch those buccinator muscles. I give her jaw a little massage because she does have a tendency to do some grinding. I go under her jaw and I just give her a little stroke. And that just helps with swallowing sometimes. All right. So the first video is of the facial massage, and what I do, I target the sensory system. We increase awareness. Think about children who drool, but also just to decrease hypersensitivity. I have some children, I couldn't even touch them on the face, and this is just a nice way to start. The bean bags, it's just another level to augment that facial massage, lip tapping, because now you added texture. And the other example I wanted to give you was a jiggler, and these are all the tools from Talk Tools that I use. And the jigglers, so think about, we've gone from hands to now textured bean bags to vibration. So again, we could work with children to increase sensory awareness, but we could also work with children just to desensitize them, not to make them so defensive. So there are other videos that I wanted to share with you, and I don't know, for some reason we're having this technical difficulty, but so there's, if you're familiar with the Talk Tools products, there's a Mickey Mouse ear attachment to a Z5. I use that to target standard feeding. If you think about the ear that's attached to this vibratory stick, it helps with the lips to swipe the food off. Again, go back to sensory. It can desensitize the lips, but it also can increase the sensory feedback. When I started out with Karina, I used this with purees just to help her gain more awareness of her lips to start that motor function and to facilitate the M and the B and the P sounds. I use a chewy tube, and again, you'll see these in the videos, that the chewy tube we put at the position of that first back molar, and the child starts biting. And again, this is to start to strengthen the jaw muscles and to start facilitating chewing for solids. So what are other factors that can impact feeding and speech? Well, first is muscle tone. It's the natural tension of a muscle that's at rest, and that's our default. We may see some children who just present more in a slumped over manner, or we may see some that are more rigid, and that's their muscles at rest. That's their default. Our nerves are continually firing from the core to the brain, from the mouth to the brain. So if there is a physical disorder of low tone or of hypotonia, or of high tone, of hypertonia, it can impact feeding, motor function, and speech. So I go back to my early days of training. I was so fortunate to work with OTs and PTs who taught me how the body can function. And just moving forward in my career, aligning myself with certain therapists who I really considered the best in their field, working on that motor function, and having them teach me how to get optimal postural stability. Remember, stability creates mobility. Just as a muscle can impact the function, the structure, also a structural anomaly can impact function. So I'd like just to take a moment to speak about tongue and lip ties, or we refer to them as a frenum. So it's a little piece of skin. If you take your tongue, put it under the upper lip, the tissue attaches from the bone to the lip. So this way, we're able to do this. Every muscle, our skin, it's all attached by these little pieces of tissue called fascia. It's the same with the tongue. I'm lifting my tongue, and you can see the piece of tissue or the piece of fascia under the tongue. So now think about how the lip rounds, how it tenses, how it protrudes, how it swipes the food off the spoon for feeding. But think about the function for speech. Oh, ooh. Now, if the lip, that tie is too tight, I'm not going to be able to round my lips. But now think about the tongue. If that tether, that tissue is tight, how is my tongue going to get the food to the back of the mouth? So it's a very important tissue tether to look at, because if it's restricting the function of the tongue, how is it going to move food back? Go back to that cookie. If you bite on it and that food is in the front of your mouth, how is the tongue going to be able to move it to the back? Think about sounds. If you make the sounds out loud, t, t, d, n, l, our tongue has to lift up and go to the top of the mouth. Again, if that tie is a little tight, it's not going to be able to. So if I evaluate a child that has tight tethers, I may start with some motor exercises and then refer to an oral surgeon for a release. Um, in many cases, feeding is important for nutrition, but when we also have organic diseases or biological diseases, such as a failure to thrive disorder, it's a significant interruption to, the nutritional development of children. Failure to thrive children have poor oral, sensory, and motor skills, and this can lead to G-tube feedings or NG tube feeding. So an NG tube is a tube that goes in the nose and passes through down to the stomach, or a G tube is a button that is the tube is right into the stomach. So, I need to work closely at that point with my team. That's usually the OTs, nutritionists, GI docs, because we need to focus on the oral sensory component. I need to work on nutrition, especially when they start to become early feedings, because the goal is to eliminate the tube. I'd like to speak a moment about teeth grinding, or what we call bruxism. A lot of parents will ask me, well, what causes it? And it could be a couple of things. Think about feeding. Go back to that cookie. If the tongue is not moving the food over to that first back molar where the jaw muscle is, it doesn't get input. We bite and swallow 1,000 times during the day. Think about the input through feeding, through swallowing our saliva that our jaw muscle gets. Think about the population of children. They may be just eating in the front of their mouth. They may not be eating. They may just be eating purees. So because of the poor intraoral muscle function, they may want to grind. Also stress. A lot of these children work hard just to sit or to move. And that could be very stressful on the body. So, keep in mind about the input that the jaw muscle receives throughout the day. And think about also a deviant swallow pattern. If a child is just swallowing by protruding their tongue, again, that jaw is not getting input. So I have some videos of exercises that I do with Karina, because Karina grinds, although she's not grinding that much anymore. I maybe hear it, or the team will report to me they're hearing it maybe once a week, which is amazing. So yeah, I'll send those videos to either Bina or Sheldon to share with the group so you can see them.
Frozen fruit is wrapped securely in gauze and then placed on the first back molar. Karina then engaged in a bite and release pattern. This exercise strengthens the jaw muscle while providing sensory input.
So let's talk about speech. I'm just looking at the time. I'm just going to go a little more quickly. So I'm going to go back to Sarah Johnson again. Speech is the result of 4 critical elements of muscle movement: awareness of the muscle, placement of the muscle, the strength of the muscle, and then the actual production. So the awareness, we have the sensory component, the placement. I use those therapy tools to help get the muscles together. The strength, the tools also help with the strength to get those muscles stronger for function. And then we work on production. So I continue to work on the placement in order to get production. And I'm very eclectic. I use prompt, I'm prompt trained. I use Kaufman cards. I use repetitive activities such as nesting cups. Put it in, put it in, put it in. I always try to start with vowels, because vowels constitute 80% of the intelligibility of our language. So I'm going to say a sentence to you using only vowels. I, uh, uh. Now I'm going to say it with just the consonants. Okay, what I said to you is, I own a Honda. So think about the clarity of that using the vowels and the contextual reference. And then when I did it with the consonants, you lose a lot of sounds. One of the areas that I feel is often most overlooked is respiration. You need air for respiration to breathe, but you also need air flow for speech. Our articulators control the airflow. So I use various techniques to teach airflow. I may have a child kind of on a wedge on their back, and I'll start to tickle. And when I find that tickle spot and they start to laugh, what are they doing? They're getting air. They're making sound. And I may do some abdominal compression. I've worked with OTs who have taught me active rib activation exercise. I may do truncal rotation techniques just to compress the diaphragm to get more air for airflow and for sound. And I may do this several times to get speech. And once it connects, and then we go to a horn. And once they start making that connection, I need to take a breath. I need to hold it and control it in order to speak. And once it clicks, it stays. A lot of children that I work with also have motor planning disorders known as apraxia. And apraxia is when a child has difficulty getting into that placement in order to reproduce the intended sound. And an example I always give my parents, believe it or not, I'm half Italian and I understand it more than I speak it, but I know some words. And I'll give them an Italian word and they'll look at me and I'll say, now repeat it. They know where their muscles should go to reproduce the sounds. They have no idea what I said, but it's a good example of what apraxia is. And again, there's no single approach to working with the child who has apraxia, but it's intensive and frequent therapy that works. So I see, we're getting close to the end of the hour, and I'm happy to take any questions at this time.
Let me go ahead and stop the recording first.
Okay.